Good morning, delegates and faculties. Today I am going to talk about cataract screening through technology, torch and DDO. First of all, our institute lies in the most underdeveloped part of Jharkhand, that is Santhal Pragna area, a tribal belt divided in basic health facilities and awareness. Observing these challenges and cope up with this, our department has decided to train our nursing officers, undergraduate students, nursing students, optometrist, ophthalmic assistant, peripheral health workers for community screening of patients with low vision through basic equipments. Screened patients are referred to our department for further evaluation and management. These are some basic equipments, such as we use smartphone, direct ophthalmoscope, Pelli-Robson chart, torchlight, and digital camera. First of all, torchlight. Torchlight examination is one of the basic traditional technique for external eye examination. With the help of torchlight, we can observe lenticular changes in eye. Basically, for screening cataract, we observe two findings: color of pupil and iris shadow. In color of pupil, we can observe changes in pupil color like yellowish color, blue color, black color, or amber colored. Then we will observe iris shadow. Here we are examining iris shadow. I am flushing torchlight over temporal iris and finding any eclipse sign or iris shadow over pupillary area. Here it is a case of mature cataract. We can see here cortex is also opacified, so there is no clear space, so there is no iris shadow present here. But when we observe this video, when we observe this video, we can clearly observe that this patient is suffering from immature cataract. There is clear cortex, so eclipse sign, that is iris shadow, is forming over nucleus. In next slide, I am talking about digital camera. Advanced equipments have some limitations, including expensive price and special training needed. It will be a problem for rural setups which has limited number of both ophthalmologists and basic health facilities. This technique supports the use of low cost and easy to use equipment such as digital camera. In first picture, there is normal red glow, but when we observe second picture, there is in left eye we are observing absent or abnormal red glow. The causes of abnormal red glow may be congenital cataract, PHPV, retinoblastoma, retinopathy of prematurity, etc. Next, we are discussing about distinct direct ophthalmoscopy. Used to get preliminary idea about the status of ocular media and fundus. This should be done routinely before doing a direct ophthalmoscopy. Equipment needed: self-illuminated direct ophthalmoscope. Procedure should be performed in semi-dark room. The ophthalmoscope should be kept at a distance of 20 to 25 centimeter from the patient's eye. Normally, a red reflex is seen at the papillary area. Here, our nursing students is performing distant direct ophthalmoscopy at a distance of 25 centimeter. We will follow RRR and LLL rule. If we are observing patient's right eye, we have to observe through our right eye and hold ophthalmoscope in our right hand. Same thing applies for left eye. In this video, we are seeing a shadow against red fundal glow. This shadow is strongly suggestive of any opacity, which may be cataractus or through other things like vitreous hemorrhage, corneal opacity, etc. Pelli-Robson contrast sensitivity test. Contrast sensitivity testing is similar to visual acuity testing. The goal of this test is to find out how easy it is for you to separate an object from its background. Cataracts can decrease image contrast. This happens because the cataract can cause light scattering and glare. This is Pelli-Robson chart. Letters are arranged in triplet forms. When we go from upward to downward, intensity contrast decreases. In this video, our undergraduate student is performing Pelli-Robson contrast sensitivity testing. This patient is suffering from cataract, so he is able to read upper 2 or 3 lines, but he is unable to read lower lines. Tele-screening. We perform tele-screening because, as we know, that our institute lies in tribal belt, so there is very low accessibility, so we can outreach peripheral setups through tele-screening, reliability with invent of automatic artificial intelligence. There is increased reliability. It is time saving. We can perform early screening, health awareness. We can, through tele-screening, we can aware people about their ocular comorbidities. With tele-screening, we can timely referral is possible. Disease screening, disease burden is decreased due to performing tele-screening. Further, tele-ophthalmology has the potential to become a time and labor-saving method with the assistance of artificial intelligence, online electronic health record systems, smartphone apps, and cloud-based platforms are accessible portals for tele-screening. Take-home message. With mere use of basic instruments and some training, we can address vast majority of cases which are neglected and unseen due to their geographical location, poor economic background, unawareness, etc. All patients screened for cataract through outreach programs require a comprehensive eye examination to identify ocular diseases other than cataract. Provisions must be made for health awareness and strengthening basic health infrastructure. In this photograph, we have conducted a camp 2 to 3 months back in which we used our basic equipments with artificial intelligence to screen out cataract, not only cataract, but also other vision-threatening diseases like diabetic retinopathy, hypertensive retinopathy, glaucoma. So tele-screening is very useful. We conduct this type of screening in our department every 3 to 4 months interval.